So hi everyone, my name is Phedias Diamandis. I'm a neuropathologist at the University Health Network, and I want to thank you for the invitation to speak today, particularly about artificial intelligence and pathology, with a focus on implementation strategies that we've been working on over the last few years. So my disclosures, I have no financial disclosures, but I will be encouraging participation in our initiatives throughout the talk. So please be aware of that. Particularly, we have two major implementation initiatives, one called PHARAOH and one called Codito. You can access them at these links. And they're really meant to be crowdsourcing tools to help implement AI in both healthcare and the general public. And of course, these are for research use only. We're still just trying to figure out how to use these tools. So the idea of using them early is to develop an understanding of how they work and where they work best before we can actually use these for really important decisions like the ones we make in medicine. Okay, so a little bit about me, just so you understand the journey that led to the motivation and interest to study implementation strategies. When I started my clinical practice in 2016, this was when the height of the deep learning in medicine boom was reaching its close to its zenith, and really many people like me were worried about the implications of deep learning in medicine and diagnostics and whether we'd have jobs in the coming years. And so, I did the only thing I could at that time is I just started writing about AI and pathology in hopes that at least I can learn about what's about to take place. And this was a very interesting time because if you talked about AI, that was enough to get funding. And so even though I was just writing about it just to kind of document what was about to happen, I soon started my own AI lab with these funds that we got, and started contributing to the research efforts on how AI could be used in pathology. And again, to be honest, I thought this was going to be a very temporary period, just given the amount of hype and powerful capabilities that we were seeing at that time. I really didn't think that this was going to be a long journey. And we ran out of ideas. We didn't plan to have ideas that lasted more than 4 or 5 years. So, just more recently, we decided to take matters into our own hands and start thinking about ways to start implementing these tools that we've invested a lot of time and energy in developing into everyday life, and hopefully also the analysis of histology. So here's the outline of my talk. We're going to go over some basics about pathology and how deep learning is used in my field. We're going to talk about some implementation challenges that I think have been kind of encountered along the way. One I'm going to be talking about today is called technology consumer incompatibilities. So this idea of trying to do what works in one field and trying to adapt it to a completely separate field like molecular medicine, and some of the challenges I think that were encountered trying to marry the two different fields together. And then another kind of challenge that we've encountered is what's called partial solutions. So trying to solve a problem that may actually only be part of the problem that professionals face on a day-to-day basis. So these edge effects or these extreme cases that we may not incorporate into kind of research settings are in fact quite common. And that's why perhaps deep learning and data are not enough to solve these problems as originally thought. And then, of course, what I'm excited to talk to you about today is solutions. So we have two, again, as I mentioned, Codito and PHARAOH, and I want to tell you how these fit into the implementation plan that we envision for AI and pathology. Okay, so let's talk about some basics. So I'm a neuropathologist, so I'm interested in nervous system diseases and particularly brain tumors. And brain tumors can be diagnosed across the full spectrum of the patient journey. On one end, visual inspection and looking for abnormalities on imaging in an emergency room can often make a very accurate diagnosis, or looking at someone's skin for other stigmata of neurological disorders like these neurofibromas. You can make pretty accurate diagnosis, at what's called the point of care, at the bedside. And most of these types of technologies are pattern recognition, right? So what we see with our eyes, the problem with these, of course, is that they're fairly qualitative. So on the other side of the spectrum, we have more quantitative and objective tools in medicine, sequencing, whole genome sequencing, genetic testing, and these are very, very accurate. Often they're very discrete with specific mutations having specific diseases associated with them, but they take a long time, and they're quite costly. And that's why I'm really excited about pathology, because pathology exists somewhere in the middle where you can get very accurate diagnoses at a very acceptable cost. And so I think they form a fundamental backbone of the medical care system because of this favorable properties. So what are the steps that I do on an everyday basis, just so we know what kind of steps we can try to automate with pathology? Well, one of the key steps is we look at these tissue sections as shown here that are stained with hematoxylin and eosin. This is a pink and purple dye that allows us to see the structures of tissue. And usually the fundamental concept in pathology is that when we see abnormalities in how tissue architecture is made, they're usually indicative of a specific disease. And you can diagnose those by looking at those specific patterns. As I mentioned, there's more, we're in this era of molecular medicine, so there's a lot of additional biomarkers that we have available, mostly through bread and butter immunohistochemical stains. And so once we have a presumptive diagnosis on the H&E exam, we can incorporate other more advanced molecular studies that are then integrated into a report that allows clinicians to make a plan with the patients regarding their treatment plan. There's more advanced molecular studies like sequencing and other biomarkers that we look for, but these usually happen after because they take quite a bit of time. So it's best to let the patient and the care team know what the kind of working diagnosis is. So what are the advantages of this approach? It has excellent turnaround times. There's low tissue requirements. It's very cost effective, but it's not perfect. There's a lot of manual steps, and it's qualitative in many of these areas. So it'd be nice to have some more quantitative tools to help supplement our kind of artistic impression. And so the real breakthrough happened, again, over the last decade with this kind of explosion of convolutional neural networks, where, we've seen that similar to our visual system, where light goes into our eye and is processed by these networks of neurons that kind of exist in these different layers, and then kind of are integrated together to help us perceive what's in the world around us. We know that we could effectively reproduce this to some degree in an algorithm that allows that allows us to interpret how pixels are arranged on a picture and synthesize that information into a intelligent conclusion about what's being seen. And how this works in pathology is that you take large amounts of cases from your archives that have diagnoses, that have the benefit of being examined quite closely. You use the labels, or you relabel them to ensure you have features of interest, and then you feed them through these neural networks. And by analyzing each and every pixel with the associated label, the neural network is able to create a model about which pixel patterns usually correlate with which specific labels. And once you've done this with extensive training, you can then deploy it on future images. And again, by analyzing individual pixels and their patterns and their positions on a slide, it'll be able to give you a fairly intelligent interpretation about what's going on. And this works remarkably well. So this is, I haven't changed this slide since we started because, I actually think some of the initial examples that we've developed are some of our best. So, once you've trained these neural networks, you can train them to recognize different tissue patterns, and then you can actually get them to color code the slide and quantify how much of different tissue patterns they see. And of course, this is quantitative, right? So before, I would have to estimate how much of a specific slide has tumor on it or necrosis, and now these can be automatically generated using a computer. And as a pathologist, I would say that these are fairly very accurate. And so if we can identify tissue types, why can't we make diagnoses? So ongoing efforts in our group are focused on not just identifying where the tumor is, but saying what type of specific tumor there is. So this is a kind of a pie chart of the different types of brain tumors that one would expect in the general population. So we focused on the 4 main common tumor types, those of the peripheral nerves, schwannomas, meningiomas, metastases, and gliomas. And when you make a model to recognize and differentiate those different tumor types, you see that you can get actually very impressive results with almost 100% agreement with the final diagnosis in this case. So this is another paper from a different group that we always go back to because it's such a great paper and really shows just how powerful this technology is. This group tried to use a similar strategy to differentiate different types of lung cancers, and also take it one step further and try to predict mutations of those cancers just by looking at those $2-3 stain H&E stains that we generate on each slide. So here are some kind of performance metrics, ROC curves of their ability to accurately predict different types of adeno and squamous cell carcinoma of the lung. They do this fairly well based on these numbers on both formalin fixed paraffin embedded tissue sections, those larger sections, and even on smaller biopsy specimens. So this is very impressive results. And what's probably magical is that not only can they identify what subtype of tumor this patient may have, but are able to, in a fairly high degree, much higher than random, predict possible mutations in these patients just by looking at their H&Es. And while the real world use case of these may be somewhat limited to academic and kind of low income countries, I do think it demonstrates just how powerful these types of workflows can be. And these are a very nice group. They did exactly what they should. They mentioned that they've generated a generalizable approach that can be applied to other cancer types, and they made their algorithms available on GitHub for communal use. So these are the types of papers where you show up to your work and then you read them, and then you say, I should probably look for another job. This is truly a transformational discovery made by this group. But 3, 4, 5 years later, we're still talking about integrating this into our practice. And so one has to, again, begin critically thinking about why is it taking so long for such a transformative workflow to become part of day-to-day practice. Surely anyone would want this co-pilot helping them with their diagnoses. Of course, there's some ethical and quality control implications that need to be ironed out, but at least in a research setting, this should have become standard of practice in my mind. Now, you can say that's debatable, as this is 5 or 6 years, a long time for something to be widely adopted. So let's see. So what does implementation look like in pathology? So this was one of the major discoveries in our field, IDH1, IDH2 mutations in gliomas, in glioblastomas, fairly unknown in 2009 or before then. And in a relatively short amount of time, 7 years, it not only was adopted, but actually became integrated into our kind of diagnostic manual. And so it was being used even before 2016. But in 2016, we fundamentally changed the way we think about glioblastoma and write about it in textbooks because of this discovery. So probably a 5 to 7 year window should be enough for something that's transformative to reach clinical care if you look at other types of discoveries in pathology. Okay, why don't we do the reverse? Let's see how long. Maybe the problem is with artificial intelligence. Maybe pathology is poised for adoptions and innovation. What about artificial intelligence? And probably the best example is one of the more recent examples, ChatGPT, where from the day of its release, it accumulated 1 million users in 5 days, 100 million users in 2 months. So we're talking about a truly transformational and scalable technology. And so I think when you kind of combine these two things together, there should be reason to be concerned if something truly promising is not yet in practice, given the time frame of these other types of technologies in artificial intelligence and pathology. Now, someone can say, well, what's the rush, Phedias? It's inevitable. It's inevitable, right? And the longer that this is delayed, perhaps the better you can sleep at night, knowing that you're not competing with robots to do your day-to-day task. So, you should be actually quite happy that this is taking longer than expected. But that's not the case, and I'll tell you why. As a histologist, the path to my protected employability is not only that I can do things better than a robot, is that my art and the art and skill that I've spent 20 years mastering still exists for at least the competition to happen. And the way I see it is, I'd rather a robot take over histology than have a scenario where the community abandons histology because of other competing technologies. So now we can make diagnoses just by taking the piece of tumor and analyzing its molecular properties. We don't even need to make a slide. Technologies like single cell sequencing allow us to see the composition of cells and the composition of tissue without having to make a slide. And there's emerging liquid biopsies that are allowing us to make diagnoses without even having to do the surgery. So as a histologist, someone that really admires looking at tissue, the only way to prolong that existence of tissue biopsies and sections is to add value, is to make sure that histology is adding value. And a tool like AI and pathology and histomics is really something that elevates my profession rather than brings it down. So I think this is an important concept for all pathologists to realize. Some of us are very self-conscious about AI reading slides, but really we are really histologists. So we should try to preserve the art as long as it provides value for the patient. So let's go back to some of the challenges and see if we can resolve them. So back to this wonderful paper, what could have gone wrong? And I think they did the right thing, right? They published a paper in the medical literature just the way that IDH paper published, and they made their code available as they should have. But I think the problem is that perhaps they were thinking too much like biologists in a system that is not built for AI technology adoption, right? We're in an era of molecular medicine, and so molecular technologies are going to be adopted quite quickly. But just by making code available, that's not going to be very useful for people that have gone to medical school and departments that may not have the right tools to implement those technologies. So we need to take a page out of ChatGPT and make the product accessible to people from the day that it gets published. I think that is really the transformative takeaway that I took from ChatGPT, is that they just made AI so accessible to the general population. There was no incompatibility. If you have an internet connection, you can use the most up-to-date AI system in the world. And I think that is how we need to think about AI in pathology. And that's what we've done with Codito. The first tool I want to discuss, some of the students in my group and myself, we've developed this landing pad where basically you can log in and post your algorithm, and other people are posting too. And what this means is that we now have a common marketplace where users can come, they can pick the algorithm that's important for their specific needs, and then run them directly on the internet. And I think that's very, very powerful, because they don't need to have any hardware, they don't need to have any coding expertise. All they really need to have is digital slides, which is what they should be able to have, because that's what their profession allows them to have. And we need to make the tools accessible to them in a very streamlined manner. And that's what the goal of Codito is. Codito is free to use, it's open. So if you have a code that you think is useful, you can upload it and make it available to other people practically within hours, possibly quicker, because we're streamlining the process. And I think that's really the power of this first implementation strategy, is we want to make the user interface an afterthought for AI researchers, but we want to make it so they don't have to worry about that. They can just use our platform to improve the reach of their AI tools. Okay, so let's look at some other aspects of the pathology workflow. And our logic was, well, maybe one of the problems with implementation is that, these H&E based studies are really only solving one portion of the day-to-day workflow of pathologists. So if we can solve the immunohistochemical interpretation and integration, then maybe there'd be a bigger interest in using the tools much more quickly, because it's actually doing exactly what these pathologists would have been doing anyways. So this is an immunohistochemical slide of a proliferating tumor. And what we're asked to do here is to try to quantify this, this proliferation index. And so we're using what's called MASCAR CNN. It's a variant of convolutional neural networks to identify the different instances of cells, count them as positive or negative. And what we find is that when you ask pathologists to estimate scores and you compare it to the AI score, you get a very strong correlation between the two metrics. And actually, the agreement between pathologists and AI is much higher than pathologists with themselves. So it suggests that AI provides this middle ground of estimations that, this is a good task for AI to do, to find consistency between pathologists. And then one of the other problems that we faced is that, okay, we can quantify immunohistochemical stains, but sometimes the orientation of them makes them very difficult to integrate with the histological information, because this, as this slide shows, it's upside down. As humans, we can kind of align these different sections, mentally, and allow us to interpret what areas of the slides are positive and what area of the slides are negative. But this is much more difficult to do in a kind of computational setting. So we borrowed another kind of AI algorithm called SIFT. This allows you to align slides using kind of general features. And because of this, we can now cross-reference what areas of the slides are truly positive and what area of the slides should be interpreted as negative. And because of this, we can now generate these fully integrated reports, just like the ones that pathologists would type out, and have all the details they could ever want available on a specific report. And all they need to do is just proofread it, verify that it's correct, and sign it out. So we thought this was going to be a high value proposition for our clinicians. And again, it's another report just showing another related glioma, where we can now subtype gliomas using these reports and document how this subtyping was made. And so we thought we had a home run. And so I went to my colleague and I said, let me show you what I can do. Are you interested in using this? And he said, this looks amazing, Phedias. This looks absolutely amazing. But is it possible for you to adapt this to include one additional tumor? And that's really where I saw mentally things starting to fall apart again for implementation. And that's because these are what's called partial solutions. In research, we may focus on a very narrow solution just for simplicity, but the real world has what are called edge cases. So there could be different clinical circumstances that you need to consider, other types of lesions. People have different genetic backgrounds. There's different types of surgeons. And so making a kind of one size fits all, while good for the research setting, may not be enough for implementation in the real world setting. You know, each neural network is designed to kind of carry out one specific task, but there's hundreds of tasks that we need to fix. And again, every task is going to have someone's own personal preference that they want to have included to be excited to use it. And then there's other professions, there's other subspecialties. So we have to make now an algorithm for each individual problem in each different specialty. We need to try to cater those to the specific needs of individuals. So really, if we want to implement this properly, we're going to need to make an encyclopedia of neural networks that can be used in a case-by-case basis. And we thought that this was impossible. We thought that, okay, you know, either we solve this problem in a kind of more generalist way, or we have to quit doing what we're doing. So we thought the only way this can be solved, or at least this is what we thought, is through a crowdsourcing solution. So instead of trying to be like Encyclopedia Britannica and hire a bunch of curators to curate the encyclopedia from you know, across the 50 volumes or so, we want to make a encyclopedia where people can contribute and we can populate things through crowdsourcing. And that's exactly what PHARAOH is meant to do. It's meant to be a tool that a clinician can upload a slide of interest, regardless of what field they're in. The computer will do some pattern inferences to provide some groups of patches that are likely have similar morphology. This makes it easier for the clinician to annotate these slides and provide feedback to PHARAOH. And then using this iterative process, they can create a custom classifier that meets their idiosyncrasies, that meets the requirements for that specific task they want to automate. And then they can share that with other people in the field. And so this works very, very well. This is an ovarian cancer classifier, uses the same type of efforts that we made to make those reports that I showed you. But now Dr. Noor Al-Faswani from Saudi Arabia has adapted that neural network for ovarian cancer. So this classifier now that she's developed allows her to classify different tissue types in ovarian cancer, and she can cater this. She can continue to cater this until it meets her specific needs without having no hardware, no software. All she really needs to do is have internet connection and have expertise in the area. Here's another one, a colorectal cancer by one of her colleagues in Saudi Arabia. This works extremely well. It's generalizable. This person has never participated in any AI initiative prior to this collaboration. So this is PHARAOH, pathologyreports.ai. We're looking to expand this now to anyone. Anyone can participate. If you have histological expertise and available slides, even if those slides are coming from the internet, we want you to contribute and make your own catered model and share it with the community for communal use. And coming soon, we're also going to have immunohistochemical stains. So these are the tools that I have for you to disseminate AI. We have Codito. This is more for experts that know how to code and want to improve the reach of their algorithms. We do have a focus on pathology, but it is subject agnostic. So if you are passionate about AI and have an algorithm that you want to share with others, please do use Codito. And on the flip side, if you're a pathologist listening to this and you want to help, please do share your model with, please do develop an algorithm on PHARAOH, pathologyreports.ai, and help share it with the community so we can build out and populate all of histology with AI tools. So I'll stop there. Thank you for your attention. Special shout outs to the Codito and PHARAOH team that have really worked on these implementation strategies, our funding sources, and just the whole team at large. So thank you very much, and I look forward to your questions.